Good morning, everyone, and welcome to Simulgram Rounds. Our presenter for today is Dr. James Boehnlein, who completed his medical school at Case Western Reserve University in his hometown of Cleveland, Ohio, and his psychiatry residency training at the Oregon Health and Science University, where he was a VA Robert Wood Johnson Foundation Clinical Scholar at the Philadelphia VA Medical Center and University of Pennsylvania. He received his master's degree in medical anthropology there as well. For the past 37 years, he has been a staff psychiatrist at OHSU's Intercultural Psychiatric Program, where he has treated Southeast Asian, Central American, Bosnian, and Somali refugees. His research has focused on cross-cultural psychiatry, particularly cultural and anthropological perspectives on post-traumatic stress disorder and long-term adjustment of traumatized refugees and veterans, the interface of culture and medical ethics, spiritual issues of psychiatry and psychological trauma, and on medical education. He was Associate Director for Education at the VA Northwest Mental Illness Research, Education, and Clinical Center from its inception in 1998 until his VA retirement in spring 2023. He was the Director of Medical Student Education for OHSU's Department of Psychiatry from 1993 to 2014, and he was OHSU's Assistant Dean for Curriculum from 1997 to 2005. He's been a consultant to the Documentation Center for Cambodia for Trauma and Mental Health Services and for staff education and preparation for the Khmer Rouge War Crimes Tribunal. He is board certified in both general and forensic psychiatry. He is past president of the Society for the Study of Psychiatry and Culture and International Association of Psychiatric and Social Science Researchers and Educators. Welcome, and we are glad to have you present for us.
And thank you, Dr. Reed. It's delightful to have a chance to meet with all of you today. And I'm talking from sunny and cold Portland. This is one of the years, one of the days per year, not many, but some where we get below freezing at night. So it's we're certainly in the middle of winter up here. I wanted to talk with you today about the role of culture in the care of patients and families. And this will be primarily a clinical talk based on cultural psychiatry. I'm going to be talking a lot about cultural concepts that are relevant to the clinical care of patients. In the clinic where I've worked now for 37, going on 38 years, we've done a lot of research over the years and published a lot on various aspects of care for refugees and immigrants, specifically trauma, and also the use of various treatment modalities such as psychopharmacology, psychotherapy, etc. But today I'm going to be focusing mainly on clinical issues, and I have no conflicts of interest. I'm going to talk just a little bit about my background and work in cultural psychiatry, just a little bit at the very beginning, and then talk about the essentials of cultural psychiatry, including its relevance for DSM assessment and formulation. And I'll talk a little bit about illness narratives and patient models of illness and healing. Our intercultural psychiatric program, it started in 1978. And currently there are about 1,000 patients in the program. It's grown quite a bit over the years. It serves 18 plus language groups from around the world. We have people from all continents except for Antarctica that are part of our patient population. And we started with refugees from Southeast Asia, and then the various groups such as those from Myanmar, Iraq, Afghanistan, Syria, Nepal, and Bhutan in recent years reflect the changes in world events that have occurred over the decades, where people have fled civil war, multinational wars, various forms of violence, torture, etc. So we have people from all different cultural groups and religious backgrounds. Uh, we have a high percentage of patients in the clinic with multiple chronic problems. Our patient population would be similar to many community mental health centers. We have a large group of patients in different cultural groups that have chronic psychiatric disorders such as schizophrenia and bipolar disorder, and of course, mood and anxiety disorders, dementia, uh, various, and then also people that have been traumatized and have PTSD because of the patient population. We have uh, a larger proportion of patients that have post-traumatic stress disorder, and of course, in that population, we have not a small number of patients that have a concurrent traumatic brain injury history. The majority of my current patients are from Somalia, Cambodia, and Vietnam. And in fact, this afternoon I'll be with my Cambodian and Vietnamese clinics. We have the way that the program is structured is we follow a medical model, but we also work on teams. So each part-time psychiatrist, we have six part-time psychiatrists that staff the clinic, work with one or more case managers from the cultural groups that are represented. And each of the case managers, uh, and they also serve as counselors running groups and also individual counseling, are from those particular cultural groups. And many of them, in fact, most of them are refugees themselves and have been trained either before or during their work in our program. Most of them have MSWs, and so we uh, we see each of the cultural groups on specific half days of the week, and we see people with a variety of ages. My current patients, just for example, in the Somali group. My current patients range from the age of 22 to 93. So we have a wide variety of folks. I wanted to have you keep this case in mind as we're talking today. And I'll get back to it at the end of the presentation and talk about the details that make this case relevant for this discussion. Uh, this is a 28-year-old indigenous Guatemalan woman. Uh, she presented with nightmares, intrusive thoughts, and memories of the murders of her parents and grandparents by the military when she was 8 years old. And she was actually present during the executions. Uh, she has a supportive husband, a 3-year-old son, and then a second child who was born during treatment. Uh, she had quite a remarkable resolution of symptoms over a 2-year period. And I'll talk a little bit more about that, of course, at the end. And the very important thing about the successful treatment is that it included a multimodal approach, medication, psychotherapy, and also involvement of her family, particularly her husband, and also therapy that focused on sociocultural issues such as her spiritual beliefs and her identity. Uh, it also illustrates the interaction between post-traumatic stress disorder symptoms and how a person functions within their family and social unit. And uh, the, we saw this we see this very commonly in the clinic. And also, when I was working in the VA system, uh, it was, of course, we had more and more ways to treat PTSD symptoms as over the decades with just the incredible growth of research and relevant clinical care for in psychotherapy and medication approaches to PTSD. But once those symptoms are treated, it's essential to be able to assist patients with to reintegrate into their family and social environment. And that very often has a cultural aspect to it. So just some basic definitions. Culture is the uh, behavior patterns and lifestyle, which is shared by a group of people. It includes knowledge, often, very often through generations, transmitted through generations, including customs, habits, beliefs, and values. So it's multi-dimensional. Now, ethnicity, which often gets confused somewhat with culture, is a particular group distinctly different from other groups. Uh, and the ethnic group shares a common history. It may share a common language, culture, or religion. And there can be distinct subcultures within specific ethnic groups. So that ethnicity can be an umbrella term, and then various cultures and religious belief systems can occur within that ethnicity. Now, culture is relevant for the DSM, and when one is making a assessment, diagnosis, and treatment plan, it has various aspects. I'm going to be talking about several of these today in the rest of the presentation. We're going to be discussing the importance of the cultural identity of the individual person who's sitting in front of you as they come in for treatment. And then the relevance of cultural explanations of the individual's illness and how that's understood by the culture and the people that the person interacts with. And then the importance of cultural factors related to the wider psychosocial environment and how those are relevant to diagnosis and treatment. And then, very importantly, the cultural elements of the relationship between the individual and the clinician. And also, since one is working with people within the family in these various cultural groups, what is the relevance for how the family interacts with the clinician? And then bringing all of these things together for overall assessment and care. So let's talk a little bit about identity. Identity has a multi-dimensional aspect, and it evolves over time. I think that's one of the most important things, and we'll talk a little bit about acculturation. Various aspects of identity include ethnicity, race. I don't. Most social scientists and really question that term and the relevance of that term because it's so changeable. It's non-specific. But the reason why I'm mentioning it is that it is often a part of the things that people fill out for various aspects of their lives. It's on forms, and people are asked to choose what race they are, which is often doubtful since it's not a specific, it's not necessarily specific, but also is multi-determined. But I wanted to include that because it is often a part of course, identity. National origin and indigenous culture are other aspects of identity, and also migration and acculturation and multiculturality. uh, uh, come into play. Acculturation refers to being able to uh, adjust or to adapt to one's culture, and that can be one's majority culture as people go through various life stages. And also, it can refer to acculturation to a uh, majority or multicultural environment after migration. And it's constantly, it reflects constant change in identity and adaptation. Um, Language is a very important part of cultural identity. And uh, those of you who work cross culturally know that people use their language proficiency in different environments. So they may speak English in when they are in majority culture situations, but may speak different language or languages at home. Uh, Age, gender, sexual orientation are, of course, all aspects of cultural identity. Uh, Religious and spiritual beliefs and practices, uh, socioeconomic status, political orientation, geographic location. Uh, for instance, when I was working for the VA and we did programs throughout Oregon for families, veterans, uh, we worked with the chaplains at the Oregon National Guard to do programs for faith communities about PTSD and other conditions affecting veterans. We we didn't necessarily encounter a lot of ethnic diversity in rural places in Oregon, but there was identity based on uh, one's work, one's location in a rural area. And it's important to consider these issues too when looking at cultural identity. Uh, Disabilities, of course, affect one's sense of self and integration with the rest of society. Uh, I mentioned work, and again, these issues and parts of identity change and evolve over time. At this point, I wanted to talk just about very briefly about some of the challenges and transitions of migration and immigration because they greatly affect identity. So, and these are universal, regardless of where a person migrates from or to. It involves, of course, uprooting, the loss of homeland, previous work, often the loss of family members, either through separation uh, or unfortunately death. Uh, Changes, it involves changes in family and social role, which I'll talk about in just a few minutes. Uh, and then changes in the family and social network. And when uh, people migrate, there's often a secondary migration within the country in which they have resettled. And that can be very fluid over time. I've had many patients over the years who have moved back and forth to various parts of the country, either following their adult children or moving back because of changes in their nuclear family that have necessitated that movement back to Portland. So that can be disruptive in and of itself, even after people have settled in the United States. So it's always important to ask about that when you're doing an assessment. Um, of course, language challenges, as many of you know who have learned new languages over the years, it's often much more difficult to learn new language as an adult, particularly as people transition through the decades. And it's a lot easier when you're younger to learn a new language. But imagine learning a new language when you have all these other pressures, and uh, it can be very, very difficult. And then cultural values can change. Uh, those values can change within the family, and also the family vis-a-vis the rest of society. Um, and what we often see in the clinic for people, when we see people in their 20s who are interacting with society on a daily basis, but may have very traditional parents or grandparents, is that there's a lot of pressure on them to uh, integrate in some ways with the society, with the majority of society, but also not abandon their uh, uh, their culture or the values that previous generations have had. And that comes up so often in working with people in their 20s and 30s. Legal challenges. And then, of course, the inability to access resources and overt discrimination. So, looking at the DSM issue of cultural factors in the psychosocial environment, uh, this includes symptom patterns of disorders across cultures. Uh, they may be the symptoms of illness may be recognized differently uh, depending on uh, the specific culture, the elders in the family who may be the first people that one consults, particularly for psychiatric illness, um, and also the cultural concepts and perceptions of disease and illness, and the belief systems that the group may hold in the understanding of illness and its treatment. Uh, the psychotic disorders are uh, the core symptoms of psychosis are universal, and they also universally cause disruption in not only an individual's life, but also their relationships with other people in their family and their adjustment to society. And that, of course, occurs in any culture. So there is not usually any question of what is going on with a person who is overtly psychotic. The etiology, of course, may be in question, whether it's substance abuse uh, or other etiologies. But and also anxiety disorders are very recognizable because of behavior of individuals. It's hard. It's sometimes quite difficult to hide anxiety and from other people. Mood disorders are bipolar disorder, of course, is also very observable. But depression is often not recognized. And it is how it presents in the clinical situation uh, does vary quite a bit from culture to culture. And so I wanted to mention that because of the differences in how uh, symptoms and behavior present. Another thing which is becoming more and more of an issue across our cultural populations in the clinic is as people age, uh, and there is a higher incidence of dementia and neurocognitive disorders. And in my experience over the last several decades, there is much better recognition across cultural groups uh, of the signs and symptoms of incipient dementia. And so it people will often present to our clinic in earlier stages than they might have 20 years ago, where they were just at home and the family actually suffered because of the uh, patient's behavior and put us quite a bit of strain on the family. So, and also dementia is a very, very good example of across cultural groups of people having much more of an understanding of the neurological basis of dementia and not emphasizing the stigma of behavior associated with dementia. So I wanted to give that as an example, as long as we were talking about cultural belief systems. Uh, and then life cycles across cultures are again universal, and I want to again emphasize the universality of a lot of the things we're talking about today, even though there are obviously specific cultural differences in working with an individual or family. uh, Donald Brown was an anthropologist at UC Santa Barbara uh, uh, for a number of years, and he came up with a chart which I thought is really, really interesting and enlightening about uh, issues of life that all cultures and people deal with. Uh, the specifics may vary across cultures, but these are all things that are part of life in human life. Beliefs about disease, which we talked about, childbirth customs, beliefs about death. How do people deal with mourning uh, and death? Uh, how how are how are people who are ill healed? Uh, Humor, music, uh, bonds such as marriage, uh, the attraction between people, uh, and the defense mechanisms that people might use to deal with daily life, and of course rites of passage, which are fascinating and also very relevant to all parts of medicine. I wanted to zoom in a little bit about other aspects of the social environment. Uh, the family microculture is the core of people's existence, really across cultures. And it's so vitally important to understand that, particularly in clinics, which serve a broad cultural base. Uh, Many times, uh, uh, decisions are made for the patient's care by uh, collective by the collective family, and particularly for those with chronic psychosis, such as schizophrenia or bipolar disorder. Uh, it's it's so important to have the rest of the family as allies in treatment, because not only are they going to bring the patient for, say, their monthly depot antipsychotic injection, but they're going to be, supervising oral medications at home, integrating the person into family events, uh, and religious and cultural events. So we have across cultures in our clinic, we have a number of people with chronic psychosis who are uh, uh, married, who are doing important roles, parental roles with children, and participate in their culture and social support systems. One thing that I might say at this point, which is interesting, is that we have a lower prevalence of substance use disorders in many of our clinics because of the religious and cultural prohibitions. So that doesn't mean that there wouldn't be uh, people within, say, majority Muslim cultures or uh, some Southeast Asian cultures that would not have substance use disorders. Of course, that does exist, but uh, it's in our clinic, it's often easier to treat people with serious chronic psychiatric disorders such as schizophrenia because they are not concurrently using substances and have not had a substance abuse history. So that's really helpful for us as clinicians. Uh, the family microculture is important in establishing secular beliefs and values and also religious beliefs. Um, and the, as I mentioned a little while ago, elders are often the first line of for people within the family to, if they're having behavioral problems, relationship problems, et cetera. And then the extended family is as I mentioned, vitally important. And the extended family may have a huge impact on the individual and the nuclear family that we're working with, even though they might live in the other part of the country, or they may live back in the uh, homeland that the person came from. And those connections can be both stressful and helpful alternatively. So sometimes our patients have an increase in anxiety because they're uh, being uh, because money is being requested by the family back in the country of origin. And when the family here does not have adequate resources, but they feel great pressure from the extended family. Uh, on a positive side, over decades, people um, uh, will go back and visit family members and are often rejuvenated. Uh, uh, the I've seen it work both ways. Sometimes it's disturbing when people come back from their trips because an elderly family member has had a more progressive dementia, and it's hard for them to leave seeing that. On the other hand, the visits back to the home country can be renewing, and especially when people have come from conflict zones, to see things being rebuilt or more positive than from when they left. The other thing across the cultures that we see uh, in the clinic is the importance of collective decision making. That it's not to say that autonomy is not important or does not exist, but oftentimes people expect more, patients themselves expect more collective decision making, especially if they're quite ill. Um, and as clinicians, we have to balance uh, our own cultural values for autonomy and independence with the what may be the cultural expectation for a more collectivist view of decision making. And as I mentioned a while ago, that is often a sense of conflict for young people in making decisions for their lives, for their own families, for their careers, and still, uh, you know, being in positions of decision making in their own family, their extended family, in helping elders or other ill brothers and sisters, for instance. In fact, um, a patient I just saw yesterday in one of my clinics where she was a torture survivor as a teenager in her country of origin, and she has her own children now, uh, and she is also in the position of being sort of the rock for the extended family who's had a lot of difficulties, there's been some serious mental illness in some of the extended family. And she is not only raising her children, but she's uh, also attending advanced education while at the same time being almost like a case manager for a couple of members of her family, and the and involved in collective decision making for those family members. So social and family roles greatly can change. Gender and age roles and role reversals. And these role reversals also can cause significant anxiety and dysfunction within families. Uh, the those are negotiated over time. They change over time um, as people age, uh, and again, this is all a part of acculturation. Language, uh, spoken at home and in public, may vary, and people even in our appointment sessions with patients, we often use a combination of English and the person's other languages. And we have our case managers present during the great majority of our sessions. With people who speak fluent English, we don't always have the case managers present. It depends on the patient. But the great majority of sessions are with the case manager. And often the case manager in some of the cultural groups, such as the Southeast Asian groups, have been working with the patients for literally for decades. And they know the family, they know the patient, um, and they also help us with obviously the language and also learning the culture, which is an ongoing task. Uh, Also, languages can define behavioral and physical boundaries too, and uh, also the issue of confidentiality with ethical issues involved with decision making, which are, as I mentioned just a few minutes ago, uh, uh, that overlap with the issues of autonomy and on the one hand, and collective decision making on the other. How do we communicate with family members who are involved in treatment? Uh, how comfortable does the patient feel, and with that? And in the great majority of the time, there's comfort with talking with other family members. I wanted to talk just a few minutes about religion and spirituality, which of course varies by cultural groups, and within cultural groups, it's also uh, it can vary. For instance, my Vietnamese group, who I've been working with for decades, about half of the people uh, are Buddhist and about half Catholic, and there's often intermarriage between uh, spouses who are Catholic and Buddhist, and it is it's relevant, very relevant, because some of the issues we deal with in trauma recovery, issues of meaning, purpose, how to explain what happened to the person in the family, often is rooted in religious belief systems, and such as explaining the meaning of life, including what is the rationale for the suffering uh, that I've had. Um, and just yesterday too, I was uh, one of my in the East African clinic, a person had just lost her son, and she was. This is about 6 weeks ago. I just found out about it yesterday, and uh, the I was talking with her and her daughter, and the patient and also the daughter confirmed this, that the patient was doing well in adjusting to it and had been going through what was obviously a normal grief process. And one of the cornerstones of allowing her to do that was her Muslim faith, which had given her strength and some kind of meaning for what had happened in the family. And that comes up all the time. Spirituality bridges religion and science. It often involves an insightful relationship between the self and others, personal values, meaningful purpose for life, and connectedness between the self and the natural and supernatural. When I was working in the VA, many of my patients had gone through various religious traditions, ranging from the tradition that they had been raised in through various other religious belief systems in a search for explaining what had happened to them as combat veterans, and trying to explain uh, their own adjustment and what would provide meaning for them in the future. And that happens, of course, in our clinic too, with many people who have suffered intense trauma. The cultural assumptions of the physician and the clinician are very important. You know, what are our own family cultural and religious backgrounds? What are the illness experiences that have existed in our own family and that we've experienced? What about our own professional education and socialization within a Western medical system? Um, how do we integrate science with many of the other issues that I mentioned today that patients bring with them? And how do we use our own intuitive knowledge and experience in patient care? Uh, what I often will mention to medical students and residents who rotate through our clinic is that you don't always have to know the specifics of the cultural belief systems or the cultural traditions, particularly when you're working uh, in training or early in your career. Uh, but it's it's more important to understand some of the general cultural issues that we've been discussing today, uh, and also being, the universal thing of being yourself in those interactions with people, because patients will be able to pick up if you're not being authentic or truthful, uh, and that it's much more important to uh, be yourself and to look at some of these universal issues. So some of the skills working cross-culturally, uh, interviewing, differential diagnosis, treatment, using one's foundational training uh, with attention to culture on top of that. So recognizing cultural transference and countertransference, uh, working with allied mental health professionals, translators, community agencies, um, and being able to bridge the gap between cultural knowledge generally and management of specific clinical situations. Obviously, if you're in a psychiatry emergency room, you're going to be focusing on life and death issues and uh, oftentimes important core medical issues, laboratory values, et cetera. Uh, and that initial contact in an emergency situation may not include, by necessity, a lot of awareness of cultural issues. But as you develop a treatment plan, and of course, obviously, in inpatient or outpatient treatment, that may become more important. Uh, and using sensitivity and respect, comfort with the interface of one's personal values and sociocultural background, and cross-cultural patient care. I wanted to finish up here with just a brief uh, acknowledgement of some of the work of Arthur Kleinman, who greatly influenced cultural psychiatry and cultural medicine across all medical specialties. Um, and his cultural model of illness and treatment, which I've alluded to a little bit with my previous discussion. So, the importance of the patient's belief about their illness, personal and social meaning. What are the person's expectations about the course of illness and treatment? Uh, People, regardless of culture and scientific sophistication, are wondering about what is the prognosis? What is the course of this illness that I have? Um, and recognizing the conflict between different values and goals. So Kleinman came up with various questions, and these obviously don't have to be literally asked, but I think it's helpful to, in an initial assessment or as treatment progresses, uh, to integrate some element of these questions in your assessment or ongoing monitoring of the person's condition. You know, trying to get at what the person feels has caused their problem, because the belief about what might have caused it may be different than what you think it is. Why do you think it started when it did? What do you think your illness or sickness does to you? How severe is it? And what kind of treatment do you think would be helpful? Um, and then what kinds of problems have been caused by your illness? And that gets into some of the social issues that we've talked about today. So, some clinical suggestions in summary. Being aware of the dynamics and the interactive patterns of family, cultural, and religious values and beliefs. How are they relevant uh, for the person's illness and functioning? Assessing the degree of family cohesion, extended family and social support network, and the strengths of that family structure. There may be stresses and strains, like the example that I gave you of the woman who was trying to balance her own needs and the nuclear family needs with the demands that were being placed on her by the extended family. Um, Determine the level of acculturation. Don't assume the level. It may be higher sometimes in an older person who has uh, grown up in a different culture, but more rapidly adjusts. And although the acculturation is, of course, more rapid with younger individuals because of the degree at which they interact with the majority society. Validate and normalize the difficulties of transition. That includes children moving out of the house, that can reactivate feelings of loss and also symptoms of PTSD. Normalize the difficulties of transition and be able to discuss that if you as a clinician are moving on or moving out of the city or whatever, and how that affects patients. Being aware of the impact of fragility of relationships, and again, awareness of one's own biases and blind spots and strengths as a person and a clinician. I wanted to end again returning to the case. Um, this very briefly, uh, uh, this woman was treated with a combination of medication and supportive psychotherapy over the period of 2 years that she was in the clinic. And she initially presented with symptoms of depression which are very, very commonly comorbid with PTSD. And of course, she had uh, very prominent core symptoms of PTSD: intrusive thoughts, nightmares, startle reactions, insomnia. Um, and she was not really able to attend well to her uh, young son. And the husband her husband was very really a wonderful guy. He was very supportive and would come to her for each session and over the course of treatment. And interestingly, he also was an excellent source of validation for her treatment. Uh, and as she got better, as her PTSD symptoms uh, became much less, uh, she was able to interact more with her son. She had another child during the time of treatment, and she was able to interact more with. Uh, she was able to attend emotionally more to her infant child also. And we talked over time about the fact that uh, as her children interacted more, as she interacted more positively with her children and integrated with them more, she was able to, the children themselves also reacted to her in a more positive way, much more emotional way. And her husband noticed a very positive evolution in how those relationships progressed. Um, Also relevant to her childhood history and her losses, as her sense of confidence in self as a parent uh, increased. It allowed her to uh, integrate more what had happened to her, losing her own parents, and being able to gain satisfaction and meaning in being a parent herself, and being someone who was effective and was able to enjoy her uh, her role as a mother. And of course, that actually increased the support and the effectiveness of the relationship between uh, the patient and her husband. Um, so uh, I'd like to end there. Uh, we have a little bit of time for questions or discussion if anybody has those.
Thank you so much. We've already gotten a question in the chat, but if people have other questions, feel free to submit them now. So our first question has to do with how your clinic has addressed the additional stressor caused by the new executive orders that the current administration has put on immigration. Do you
Yes.
have any suggestions for support we can provide to our patients?
Excellent question. And again, that's a moving target because it's just been over the last few weeks. People, both patients and staff, are anxious about it. Uh, we don't deny that with our patients, but we don't obviously uh, say that, oh, we try to maintain a positive view of things because there are positive things that we can do. Um, and and it's interesting that you asked that this question was asked, because we are in a unique and somewhat better situation in Oregon, uh, in that there are uh, there are many more prohibitions in how, uh, for instance, ICE can access certain facilities. Our medical school has laid out a very strong directive that the if ICE would show up at any of our clinical facilities, that our public safety, our police force, be called immediately, and they are the ones that will interact with them. So that provides some safety and assurance for our patients. Uh, Also, there's always ongoing in the clinic uh, opportunities for people, particularly with chronic long-term schizophrenia or dementing disorders who are applying for citizenship to have an I-648 waiver. And we will do those for our patients if it's appropriate. And so we can actually, as clinicians, be able to provide uh, a evaluation and a report for that with their permission. Also, Oregon is the only, we have a little side human rights clinic now across three departments, us, family medicine, and medicine. And this is separate from our treatment clinic. But Oregon is the only state in the United States now that has universal funding for people seeking asylum. So the state of Oregon legislature several years ago allocated money for asylum, medical and psychiatric asylum evaluations for any asylum seeker wanting that. And so we have ongoing interactions with just superb immigration attorneys in the Portland area. So that's a long answer to the question. So.
Well, and that kind of speaks to maybe our last question, which is any tips that you have found in terms of working with other medical specialties like primary care, pediatrics, whomever?
Oh, yes. We used to have a family medicine doc come to our clinic a half a day a month for many years. The family medicine department lost their funding for that. So that was unfortunate because we were able to co-locate primary care and psychiatric care for a lot of our patients. But now with the Human Rights Clinic and the involvement of two other departments, we have input from particularly a superb faculty member in internal medicine who's had a lot of experience in doing medical evaluations for torture survivors. So she's an excellent consultant informally in the intercultural program, but much more structurally for the asylum clinic. And we have a forensic psychiatry fellowship program in our department, and now those fellows are rotating through our clinic too. So, and they have some knowledge of immigration law, which is also helpful in overall care.
Wonderful. Thank you so much for your talk. That puts us close to the end of the hour.
Okay, well, thank you so much. I'm glad I was able to meet with you today, and thank you for inviting me.
Thank you for coming.
Yeah.
Bye, everyone.